Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. Yes, I'm doing better. My voice is a little better than last week. Boy, that just totally kicks you in the butt when you have those kinds of flu hit you, cough, cold, whatever. But thank you for all the kind wishes from everyone. So this week is Top 10 Tuesday. We're the last Tuesday of the month, and I have some interesting questions that have come up on my membership from people, and hopefully you'll find this interesting. All different kinds of specialty questions, and hopefully this will help you in your practice as well. But first, the Codecast podcast is brought to you today by Part B News. Stay up to date each week with Part B News. Get the guidance you need for claims, coding, and revenue cycle. Best practices that will keep your practice strong. New subscribers can save $155 instantly by visiting decisionhealth.com/PBN155. Okay, so here we go. Number one, Terry, I'm a family medicine physician and would greatly appreciate your help in coding. And I'm the external consultant for the AAFP, or American Academy of Family Physicians, so I get these every once in a while. So it says a nurse practitioner is a PCP for the patient who desired a next plan and removal. So the NPP does not know how to perform the procedure, and the patient was then scheduled with me to remove it. I obtained consent and performed the procedure about a week later. I coded it as 11982. However, my administrator asked me to additionally code an E&M code of 99213 based on time and care. As a provider, I refused to do this as no care was needed nor provided, as the patient just received her primary care from the NP, including contraceptive counseling on a previous clinic visit. I stated that time-based billing is incorrect for this procedure other than the CPT code for the removal, which I did, and it was less than 15 minutes. Am I right in this? Yes, you are right. I did respond back and said, I've received your coding question. You are 100% correct in not charging the visit along with the procedure. This has been a long-standing rule, not only for Medicare and government plans, but commercial plans as well. If the minor procedure is planned, there's no E&Ms that is separately reported. Also, all minor procedures have a pre and post work as part of their RVU value. So you can't add that. And it concerns me that an administrator wanted that provider to do that. So I was really glad that he was on top of that. If you need the highlighted section, make sure you go to Chapter 12, page 21, and that'll tell you everything you need to know. Number two, can we code 92960 times 2 if the doctor did 2 cardioversions, one at 200 joules and one at 300 joules? 92960 and 9296059. The answer is no. Those codes are once per session. So it doesn't matter how many times you zap the patient. That is going to be just one time per encounter per session. Number 3, we have 3 new doctors here, and one has asked me about the Mitral clip billing. I know about the 62 and the Q0 modifiers if a surgeon's involved. He is thinking that 2 cardiologists can bill. He has mentioned a heart failure cardiologist for patients with functioning MR, mitral valve regurgitation. I've never done that, and everything I've read states you have to have an interventional cardiologist or a cardiac surgeon before you can actually bill that. You are correct. I love it when the coders are correct. It has to be 2 providers that have different skills. Cardiologists have same skills even if they have an outside subspecialty, as stated here, for example, of heart failure or whatever. Even if they have that subspecialty interest, that's not a separate provider. It's not a different taxonomy code. It is 2 same providers. So you would get denied on the second one. So good catch there. Number 4, a provider has an appointment with a 4-year-old and a parent to go over lab results from a previous visit. The parent showed up without the 4-year-old. I don't blame him. But can we still charge for the parent and not the patient? So obviously this isn't Medicare. If it was Medicare, you can't bill for it. They want the face-to-face. Private commercial plans, they have their own rules. So does Medicaid in a different state. And most Medicaid payers want to see the patient there as well, but then check with your state. So you would have to call or contact their payer and ask if you can bill it, or is this a cash pay? And make sure that you call and find out and document what they said first. Don't just go ahead and say, well, we'll see what happens, because that can be a problem if you don't actually have the patient there, and it could end up being just a cash pay situation. Number 5. Hi, Terry. I participated in your telehealth webinar last year, and I had a question about CPT 98016. Okay, just a side note, if you participate in a webinar and you are not a membership client, you can't come back. Webinars, live webinars, we have a Q&A section. Luckily, this person is a Coding Corner membership client, so of course we're going to respond to that. It says it's coming back as denied, again, the 98016. It meets all the criteria described that we talked about in the webinar, so I'm not sure why Medicare would deny it. I read somewhere that the patient needs to be the one to call in order to bill this. Is that correct? Maybe that's what we're doing wrong. I also have claims towards the end of 2024 where the provider billed G0212, and those also were denied despite seemingly to meet the same criteria. What information can you offer? Okay, so here's the issue there, and I actually dug a little deeper and responded back and said, what are you billing this for? And they said, as a follow-up to a visit to go over labs. No. So the 98016 is a replacement code for the Medicare G2012 virtual check-in. What this code is for, and everyone seems to get it wrong, is that if a patient has not been seen within at least 7 days or a week, and they call in to get medical advice from either a nurse practitioner, PA, or a physician, MD or DO, on how to deal with a problem, again, patient initiated. So let's say they used to have, or there's a patient that has frequent urinary tract infections, and the last time they were seen was 3 months ago, and they got Augmentin from the physician and it went away. Now they feel another one coming on, but they don't have an office visit for another 3 months because they're on every 6 months for their chronic conditions. So they call in, they talk to the provider who can bill directly, not a medical assistant, not an RN. It has to be it has to be a QHP. So it has to be a PA, nurse practitioner, or a physician. And they talk to them for 5 to 10 minutes. They say, you know what, we'll go ahead and call in a prescription, again, Augmentin, since that worked for you last time. If you have a problem, go ahead and make an appointment, but this should clear it up. Now, if they end up making an appointment, you don't get that visit, or you'd have to, send that back. That's why they call it a virtual check-in. It's basically to determine if you need an appointment. And if you don't, and it can be handled through a virtual check-in, then that's what you get. You get $10. Because let's face it, that's really worth what you're doing. You're basically saying, you don't need to come in. I'm not spending any staff overtime. You're not coming into my brick and mortar office. We're not hooking you up to telehealth. We're not doing anything. You're calling in, and I'm going to call in a prescription for you. That's it. Now, in saying that, this is not to follow up on any test results. This is not to call in prescription refills for patients. This is to deal with something that they haven't dealt with in the last week. So it can't be the same diagnosis as something they saw, 4 or 5 days ago. Can't be follow-up for that. Can't be any of that. So make sure you know what that 98016 is, or they're going to take that away from us too. Number 6, hi Terry. I just found out a couple of the payers are still pay for consult codes, which I did not know of. This came from a physician. What sort of requirements is there for me to bill this? Is it only for new patients or established? Okay. So this one's a tough one because yes, there are random commercial plans that still allow for consults, but do you really want to take the time to figure out who they are by getting all the denials and then trying to send that money or trying to then rebill that with an office visit, whether new or established? So, it's up to your staff to figure out, yes, this particular Aetna plan covers for, consults. This United Healthcare plan follows Medicare and does not. It's up to you how you want to handle it, but a lot of practices decided to just do what Medicare is doing and charge either new or established patient what's appropriate for the patient. I'm not saying you can't charge the consults if it's appropriate for that payer, and it does have a slight increase in reimbursement. The problem is, first you have to meet the criteria, so you basically have to have a referral from the other physician's office to that particular physician. You're not keeping the patient, you're giving an opinion, which technically isn't always the case. That's why Medicare stopped paying for them. And then you basically, hope to get paid on that. But here's the problem. If you have any commercial plan that says we follow Medicare on this, you're going to get a denial, and then your staff would have to rebill. Sometimes that comes back as duplicate claim, and the expenses just keep increasing. So just be aware it may not be worth it to hit or miss on that. Number 7, we need some help with an argument we are having with providers on E&M levels. Our providers, orthopedic surgeons, are leveling level 4s when a patient is referred to them from an ER or urgent care facility. Okay, so just because an ER or urgent care facility refers to you, that does not automatically mean moderate decision making. Patients go to urgent care centers because they don't want to go to the hospital. So urgent cares have kind of filled the void, if you will, of a way to get after hours care without going to sit in a waiting room for 2 hours. If you fall off a ladder or whatever, you injure yourself. And what they usually do, also they do this from the ER because, again, this is just one time, it's supposed to be just one time care, and then somebody else is supposed to take care of you. They then say, they give you a business card and say you need to probably go see an orthopedic surgeon or your primary care. So just because they're coming from those facilities, no, now you start over, just as if they're a new patient that is getting referred from a primary care physician or family practice office. So just because they're being referred from an ER urgent care facility, it just means that they're not going to take care of that patient anymore. So try not to confuse the referral with the level of complexity of the patient. I also have something in reverse here. So number 8 is kind of interesting. It's along those lines, but it's on the other side. It says, Terry, we have providers that feel if they send the patient to the emergency department, it's an automatic level 5. So, and then they said, based on the documentation below, do you feel it's a level 5? They said, we don't feel it is. So I was reading through the documentation, and one of the things that stood out was that the patient they thought could use an MRI instead of an X-ray. And most emergency departments most offices either have an X-ray machine or limited diagnostics. And so they send them to the hospital so that they can, basically get something that they don't provide. That's not a high level of care. Also remember that 2 years ago, I think in 2023, the E&M codes descriptions were updated saying that one acute uncomplicated illness or injury requiring hospital or observation level care. Sometimes the doctors are just concerned the patient doesn't have sign or symptoms, they don't have a problem, but they're coming in, to the practice, and whether it be urgent care or whether it be primary care, and maybe they fell and they didn't have loss of consciousness. They didn't have anything that they didn't have anything that really says they have a head injury, but they've got a little, butterfly tape on their head saying, just to be careful, just to observe, why don't we go ahead and send you to the hospital? That's not a high level of service. Or they send them to the hospital just because, the patient would maybe be better served with specialists they have there because they don't have it in their office. So if you're elevating care to a level 5, you have to show that this is a severe problem. This is a life threat situation. Otherwise, that's not necessarily a level 5. And I do see that happen quite a bit, and it's not automatic. Number 9, would it be appropriate to bill both the 80307 and G0480 on a single specimen for drug screening and confirmation when both tests are performed using mass spectrometry? Essentially, the sample is prepared once and both tests can be completed. So I'm not a lab guru, but I do get some of this information that can be helpful. Actually, this response comes from a good friend of mine that I sent over to her because, again, I don't do a lot of labs. This is from Stephanie Allard. Check her site out, stephanieallardconsulting.com. She's a good friend of mine. She said there are different factors that play into this, but it largely depends on the individual payer policy. There are no NCCI bundling edits, but some payers will not allow an 8 code to be billed with a G code on the same date. The other reason this is difficult is that it also can come down to medical necessity and what the order practitioner documented as medical necessity. So the 80307 is presumptive testing, and the practices or labs are not allowed to go straight to definitive test, which is what the G0480 represents, unless there's a documented reason why they need to. So for example, certain controlled substances will not show up on a presumptive testing, or there may be high-level concern due to the patient's past illegal drug use and access to street drugs that causes them to need definitive testing due to the potential relapse of risk to the patient. So overall, I know this can lead to a lot of back and forth. So what I would suggest is looking to the individual payers for their policies, then deciding from there what codes will be used and if your workflow has compliance issues. So you've got some best practices there to deal with. Now there's a question that comes up, oh my gosh, this drives me crazy. This is almost like the G2211 code, but the Advanced Primary Care Management Services. I'm really kind of sad because the CCM, Chronic Care Management, has a role, and it also put time on the codes per month. And I thought that was a great idea because it's really that self-policing. If you don't meet the time threshold, then you can't bill for it. But these services, and almost mirrored to the Chronic Care Management, have a couple of different nuances, but pretty close, don't have a time on there. So I'm seeing that a lot of practices are believing that if it's just available for the patient, they can bill it, even if they don't have any time. And I really like Betsy Nicoletti's booklet on this too, where she even mentioned in her book, when there's a month where no services are performed for the individual patient, there should not be an APCM service billed. I agree 100%. But then I have offices that are saying what accounts as a service. For example, can it be an outreach email, a health maintenance letter, or does it have to be a reciprocal phone call or in-office or telehealth between the nurse and the patient? So remember, these are virtual surfaces, so it's not something in office, but it is a reciprocal contact between the patient and the clinician, and if it's not a physician, then it would be a clinician that's under the direct supervision of that provider. And one of the top OIG issues for this, for fraud, and I know everyone hates that word, is care management services. It's that providers try and leave a message or send a message, or clinical staff does, or an email, and that's not considered care management services. It may be part of the contributions of care management, but there's no guarantee that the patient will read it, review it, understand it, or know how it will impact their care of not being readmitted to the hospital, or how it will assist in keeping their chronic conditions from not continuing to decompensate. Remember, this is not for everybody. I'm seeing some practices that are automatically enrolling, patients to APCM or CCM services just because they have two chronic conditions. That would drive me crazy. If they enroll them because they need the constant attention virtually in between office visits to be monitored so that they don't decompensate, so they don't go back into the hospital, that's what that's for. It's not for somebody that is well controlled. Let's say they have hyperlipidemia and diabetes, and they're well controlled on their meds. They're taking them. The last visit said that they are at goal. Their A1C looks good. There's no changes. Everything's great. That's not a person that could qualify for CCM or APCM. But let's say you take that same person and their sugars are continuing to be over 150. They aren't taking, let's say, their metformin or their Jardiance as they're supposed to. They are not following diet regimens as they're supposed to. They continue to end up in the hospital or call the ER. Those are patients that need that attention. Or they have hypertension episodes. They're not taking their meds again, and all of a sudden their blood pressure spikes to, oh my gosh, I've seen it recently, 200 over 100, and I'm just like, oh my gosh, this patient's going to stroke out. Those are patients that need this. It doesn't have to be that severe for every patient, but remember, you have to have a reason, not just because they have two chronic conditions or even one that could be a qualifier for APCM. But just know that I don't want to see you have to self-report, have to respond to takebacks, have an OIG inquiry, because this is low-hanging fruit for fraud. And I would just hate to see you go down a path for having patients that didn't qualify. And when you do have patients that qualify, it does lessen then the pool the reason to even have these services if you put everybody on it. So it's the same thing, and this is going to be like a bonus question since we're already at 10. It's the same thing with the G2211. I'm doing a lot of audits recently, and that's the add-on complexity code, and I hate it when everybody automatically puts it on. But I'll see a patient that's coming in for their 6-month check, and no complaints, doing well, everything looks great, see you in another 6 months. And I'm just like, okay, where's the complexity here? What the complexity code is for is that patient that now has peripheral edema and swelling, or that patient that is going to have cataract surgery, and because they're on certain medications or they're on blood thinners, your expertise, because you have a relationship with the patient, they call it a longitudinal, you have a long-term relationship, you understand their clinical profile, you have to make some modifications so that you can clear them for surgery. That's the kind of thing that requires or is appropriate for the G2211. Not patients who are coming in that look great, that you don't have to make a medical decision that is so necessary, or, and I don't want to say it life-threatening, but complex, that nobody else could make that. If everyone looks fine, it could even be, a nurse practitioner, PA, or a doctor that didn't even follow the patient, say, you look great. So be careful about overcoding, upcoding, adding codes, trying to capture services for revenue instead of for the value they actually add to the patient, because that can just lead you down a path that isn't good. Okay, so I hope everyone's taking their vitamin C. We're starting to get warm here in California. We're looking at 80-degree weather all this week. So yes, we did heat my pool so I can get some exercise in. It's been a long 6 weeks or a month without having much to be able to do that. So I need to get in and stretch out. Hopefully you're doing the same. Get outside for your vitamin D. Get some sun on your face if you can. I know it's still snowing in some areas of the country. And also make sure you go to Medicare.gov. I just had an alert, and I'm recording this on a Sunday, that they just put a short statement out about telehealth, that it's reverting back as of April 1st to the old ways. So make sure you take a look at it. If you're a membership client, I'm going to be sending you an email, but make sure you take a look. Just put, Medicare.gov/telehealth, and you'll be like, what? It was a short statement they put out late Saturday night. Probably they didn't think anyone would notice, and basically just said, as of 4/1/2025, we're not going to pay for anything in the patient's home. So where the patient's in their home. I think they're doing that preemptively because, as you have probably heard on the news or whatever social media platform you're on, Congress is just, beating each other up trying to figure out what they're doing. So with all the fraud, waste, and abuse and all that kind of stuff. And it doesn't seem like they're really getting a handle on any of the bills that are sitting there that need to be advanced. So just be aware that that's out there, and we'll try to keep you posted when we know what's going on. But for right now, that seems to be the plan, since we are just about 5 weeks out of what could change or, what may revert back. All right, everyone, have a good rest of your week. Make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.